I'm going to talk about something a little bit more boring, maybe something a bit more mundane, and this is diabetic macular edema. And sort of when to observe this, when to treat this, because this affects every single retina specialist. And these are my financial disclosures. Of note, I am a consultant for Genentech, but we won't speak on anything specific about anti-VEGF therapy. And so when we think about treating in diabetic macular edema, really clinical trials have shaped our decision-making, and the thresholds have really been divided by visual acuity. So for 2032 to 2400 diabetic macular edema, most clinical trials cover this, and we know that we need to treat all of these patients. For count fingers diabetic macular edema, we have less evidence as they were excluded from clinical trials, but real-world studies show that they have significant benefit from treatment. For 2020 to 2025 DME, we have excellent data from Protocol B, and I'd like to spend the majority of our time talking about that. And then also prophylaxis of DME, we now have excellent data from Protocol S and Protocol W. And so we've seen the famous rise and ride data and this is something that we see all too often at meetings, and we learn two major take-home messages. One is that anti-VEGF works very rapidly in the first 3 months, and that we shouldn't delay treatment for patients with 20/40 or worse vision, because if we do, they never fully recover to their potential. So the lessons that we've learned from over the last 15 years is that OCT is the gold standard for measurement, and we use center involving DME. All anti-VEGFs work for the treatment of diabetic macular edema with 20/32 or worse vision. And some anti-VEGFs may be better than others, and we won't talk really about Protocol T at this point, but I think we're all familiar with this data. And that steroids also work well, but there are more side effects, and therefore they're relegated to second line. And delaying treatment is uniformly bad. So just think about this patient. This is a 48-year-old woman. She's got blurred vision for 6 weeks, and these are the plethora of treatment options available to you. So what would you do in this situation? And does it change if I tell you that her visual acuity is 20/20 minus at presentation? And so based on our initial intuition and from our prior diabetic macular edema studies, we realized that deferring treatment resulted in suboptimal visual recovery. And this is sort of the basis and development of Protocol B when evaluating patients with diabetic macular edema and excellent visual acuity. Now think about the ETDRS for one moment. 40% of eyes in the ETDRS had best corrected visual acuity of 20/20. So this has significant public health implications. So in 2019, we finally have level 1 evidence sort of looking at this. And this was a sort of a systematic approach for the management of patients with diabetic macular edema with either 20/20 or 20/25 vision. And it's critical to realize what this study did not evaluate. This was not a study looking at aflibercept monotherapy versus laser monotherapy versus observation. Rather, this was a systematic initial approach to the patients with good visual acuity and appropriate rescue strategies. So this was about 200 plus patients in each arm looking at prompt anti-VEGF therapy, prompt laser versus deferred anti-VEGF therapy, and observation versus deferred anti-VEGF therapy. And the primary outcome was unique in that it was a percentage of eyes that lost 5 letters of visual acuity at 2 years. Because remember, there's a ceiling effect when we're looking at patients with excellent visual acuity. And the secondary outcome was mean best corrected visual acuity at 2 years. So let's cut to the chase here. There were no differences between groups when evaluating best corrected visual acuity at 2 years, and that the mean best corrected visual acuity at baseline and year 2 of follow-up was 20/20 across all 3 arms. And there were no changes in central retinal thickness across the 3 groups, and surprisingly, the central retinal thickness declined over the course of 2 years across all 3 groups. So we now realize that eyes with center involving DME and good visual acuity can be observed unless visual acuity worsens. So then the real question is, how do we apply this to our patients, and how do we prevent notoriously worse outcomes in the real world? So as I was reading the Protocol B study, a couple of questions came to mind. When and how often do they treat patients? How did they extend patients that they were being observed? And how do I do that in my own clinic? How many times were they seen, and how many total injections did patients receive in years 1 and 2? So I think we have to kind of go into a little bit of the details here. So first, when we think about that aflibercept group, these patients received monthly treatment for the first 6 months, and then the decision to treat subsequently was a change from equilibrium. If they had either a 5-letter visual acuity increase or decrease, or their central subfield thickness either increased or they decreased by 10%, they were retreated. And they were slowly extended to 8 and 16 weeks if their visual acuity was stable for 3 consecutive visits and focal laser was possible. So mean number of injections, and think about this in your own clinic. 6 injections in the first year, 2.4 injections in the second year, and this is dramatically different from prior anti-VEGF studies looking at 20/40 vision or worse. Now, how about the laser and observation extend? So this is what I call sort of the observe and extend window. They were followed initially every 2 months and then extended to 4 months if they were stable. And the rationale for treatment decisions was if their visual acuity declined by greater than 10 letters at any visit, or 5 to 9 letters at 2 consecutive visits, they were retreated. So, a couple of things that we learned. First, the number of retreatments is the number of people who needed rescue therapy was about a third in the observation group and a quarter in the laser group. And so we now know that there is demonstrates a treatment benefit of focal laser. And this is sort of one of those forgotten about topics in anti-VEGF or in diabetic macular edema, but there is a treatment reduction burden in patients getting focal laser. And then also we realize that patients, while they need a few rescue treatments, we need close follow-up to be able to determine which patients require those injections. And the number of visits required was approximately on average 6 visits per year at least. So then the question, does protocol B apply to patients who are symptomatic? What about patients with horrible levels of glycemic control? And what about eyes with proliferative diabetic retinopathy? So on average, baseline characteristics, 20/20 or better visual acuity applied to 2/3 of patients, and the mean central subfield thickness was really quite thin at about 311 microns. But realized that 50% of patients were symptomatic, and this was quite surprising to me. And they realized that it's reasonable to closely observe patients even when they are symptomatic with diabetic macular edema. So what about their hemoglobin A1Cs? On average, it was 7.6, but there was certainly a range from 6.6 to 9.1. So while we really think that we can apply this to a wide variety of patients with hemoglobin A1Cs, just be aware that for patients who are outliers, this may not be the right patient population to extrapolate from. And what about eyes with proliferative diabetic retinopathy? Well, this is only 4 to 8% of patients with PDR in the protocol B. And the current treatment options, as we know, is complicated, and we argue a lot about this. PRP versus anti-VEGF therapy versus some sort of combination of both. And really in this study, there were a low number of patients to guide treatments. We know that it's unacceptable to observe, and that really gives us a combination option, anti-VEGF alone or PRP alone. And really protocol B provides little guidance on the management of patients with DME and proliferative diabetic retinopathy. So we have to use our best judgment. So DME, when we think about patients with 20/20 or 20/25 vision, we have excellent evidence from protocol B. It's reasonable to observe initially, but we must follow these patients closely. And protocol B provides a practical framework that I use in my practice to follow my patients. And of course, many questions remain. What about DME prophylaxis? Now, this is sort of a hot topic in the US, and we learned that from Protocol S, which was a comparative study for patients with PDR receiving either PRP or anti-VEGF therapy, the cumulative probability of developing vision impairing DME was less in patients who were receiving ranibizumab, about 20% in the ranibizumab group and 38% in the PRP group. And so certainly there's a reduction in the rate of DME when patients are receiving regular anti-VEGF therapy, but the caveat is that visual acuity was the same between groups at 5 years, and realized that patients in the PRP arm also were able to receive anti-VEGF therapy. So it certainly is reasonable to wait until visually disruptive DME develops. And now recent data from Protocol W demonstrates a similar finding in patients with moderate to severe non-proliferative diabetic retinopathy. And the premise of this study was treating with anti-VEGF therapy to identify what were the rates of preventing vision impairing disease. And that was defined as proliferative diabetic retinopathy or center involving diabetic macular edema. So the 2-year probability of developing center involving DME or vision loss from BDR was 16% in those receiving aflibercept versus 43% in sham. So a significant reduction in the rates of severe complications. And for PDR, 13% developed PDR in the aflibercept arm and 33% in the sham arm. But notice there was no difference in mean change in visual acuity from baseline to 2 years. So my best evidence approach to DME is visual acuity at presentation guides my decision-making. 20/30 or worse vision, I treat everybody and I start with anti-VEGF therapy. Remember, we don't use ETDRS testing. And 20/20 to 20/25 vision, I observe these patients closely And I use Protocol V guidelines to help me in terms of making these decisions. And there's no indication in my practice to prevent DME with anti-VEGF at the moment. So I'm happy to take any questions. I'd love to hear what various treatment patterns and paradigms people are using. And thank you for your time.